might be modified to make some teaching points there, and then we'll discuss, we'll illustrate some nephrological principles and how to handle problems. These are cases that I have seen, and these are my evaluation of the cases. So if you all have any ideas, any comments, any questions, anything, please feel free to ask at any time. So first of all, I'll talk about a referral I got. Patient with 55 years, so my MO went to see the patient, and my MO called me and told me the details. 55-year-old male, being treated for infective endocarditis, had been on gentamicin for 8 days or something. The creatinine had been 0.9, normal, 5 days back. Then 2 days back it had been 1.6, and on the day of referral 3.2. So rising creatinine, 0.9 5 days back, 1.6, and now 3.2. So pretty prescribed. And then the ultrasound showed normal sized kidneys. Urine output was not measured, but the patient said he was passing urine. UFR showed 2 plus protein, moderately fearful red cells with red cell count. And they had done the urine protein creatinine ratio, and that gave about 2 grams of protein per day. And then blood pressure was 180 by 100. And referred to me, patient was on gentamicin. So that was the case. So what would you do? We give some options. Would you do a renal biopsy? Would you give methylprednisolone? Would you dialyze the patient? Would you stop the gentamicin? Would you do all of the above or none of the above? Who would say renal biopsy? Give methylprednisolone? Dialyze? Stop gentamicin? All of the above? None of the above? Okay. So I'll illustrate a few things in that case. Now, patients' problems, the disease will start with the etiology, with the cause. Okay? The etiology will cause etiology will cause pathology. Pathology will cause the presentation. So that's how it goes. But patients come to us with the pathology, with the presentation. So from the presentation, we have to work back and find out the pathology and then the etiology. And we will have to start, we have to read the presentation as well, but then we can treat the pathology and the etiology after working out those things. So how did this patient present? What is the problem now? Creatinine has been rising rapidly over 5 days. So what is it? What is that? That is acute kidney injury. Okay? So any high creatinine is acute kidney injury until proven otherwise. Okay? Why? Because if someone's creatinine is here, it should be here. Okay, there are several ways that it can go from here to here. One is it can go on like this. Okay, that is CKD, chronic kidney disease. Okay, or it can be like this and suddenly shoot up. What is that? Acute kidney injury. Or it could have been rising like this, CKD, and now then shot up. So AKI on CKD. So it could be any of those, any other pattern, but basically those three. So which one is more important to catch? The AKI. Why? Because if it came up like this and went up like this, if you miss that, it will go up like this, and the patient may be dead. Okay, there is CKD, even if you visit for a month or two, it will go up like that, so no big problem. Okay, other thing, your AKI, if you catch it in time and then do what is necessary, you can bring it down to normal. So potentially reversible. There is CKD, you might slow down the progression, but you will never get it down to normal. Okay, so always AKI has to be proven otherwise, but here there is nothing to prove. Creatinine is rising rapidly, so nothing but AKI. Okay, so what are the causes of AKI? First of all, it could be a pre-renal. Pre-renal means the kidney, theoretically the kidney is fine, nothing wrong with the kidney. But what the rest of the body should be doing for the kidney is not happening. In other words, the kidney is not getting enough blood flow. Okay? So theoretically speaking, if you transplant that kidney to another person, that should start working immediately. Well, nothing wrong with the kidney, it's just a pre-renal. In actual fact, that won't happen, but theoretically, that is it. So could this patient be having a pre-renal problem? Blood pressure is 180 by 100. Unlikely with that blood pressure, but then the patient has endocarditis. So it could be in a bit of heart rate. Okay. Now, Generally, your kidney can auto-regulate from mean arterial pressure of 80 to 180. Okay? But when you're unwell, when you're acutely unwell, auto-regulate means the kidney can maintain its blood flow with a wide range of mean arterial pressure. But when you're acutely unwell, that auto-regulate capacity goes down. So even with a reasonable blood pressure, the patient might sometimes be having prerenal failure. So prerenal failure possible. Okay? Then the patient could be having intrinsic renal failure. Second, intrinsic renal failure, something going wrong with the kidney itself. Post-renal failure, bit unlikely. Because ultrasound is normal, not showing any obstruction. You can have post-renal obstruction without ultrasound changes, but that is very rare and not likely in this setting. So, what are the intrinsic problems that this patient may be having? So, if you think of any organ in your body, your brain, your heart, your muscle, whatever, you will have basically three types of cells. Okay? One, you will have the specialized cells. For example, in the brain, the neurons, in the heart, the myocytes, in the muscles, again the myocytes, so on and so forth. Then you will have the filling tissue, the interstitium, and then you will have the blood vessels. So if there is an intrinsic problem with any organ, it should be one of those cell types. Can't be anything else, right? So if you take the kidney, you divide your specialized cells into two: the glomerulus and the tubules. So you would have to be having a glomerular nephritis. You could be having a tubular problem. You could be having interstitial nephritis. The filling tissue could be something could be going wrong, or you could have a vascular problem, microvascular problem, HUS, TTP, that kind of. Right? So of those, what could this patient be having? Right? Now, any infection, not any infection, most infections can actually cause glomerulonephritis. So there's a thing called endocarditis associated glomerulonephritis, which could be having that. Patient is not gentamicin. Gentamicin is nephrotoxic, toxic to the tubule. So the patient could be having an acute tubular necrosis because of gentamicin. Interstitial nephritis, nothing directly, but still possible. Okay? It could be any of those. So which of those can this patient be having? Okay? So look at percentage. Patient has 2 grams of protein per day. Right? Moderately fearful red cells with red cell count. Right? There are only 2 ways that the red cells could get into the urine. One is leak from the glomerulus. Okay? An inflamed glomerulus could be leaking red cells. Okay? Or the tubules, the glomerulus is a filter, penile, seal. Okay? So it should be keeping in the good stuff, filtering out the bad stuff. Okay? So for red cells to get in there should be a hole in the penile, either inflammation or some damage or something like that. Okay? The tubules can't generally secrete, the tubules secrete and reabsorb. So red cells will not generally get in from the tubule. Or it could be lower down in the urinary tract, renal pelvis, ureter, bladder, in there. Okay? So now this patient has red cells and red cell cars. Red cell cars happen when the red cells flow through the tubules and they form into tubular structure and then they go down. So we know that this blood is coming from the glomerulus. Secondly, this patient has fairly heavy protein. Okay? So the penile, the sleeve is the glomerulus. The tubules secrete and reabsorb, they will not produce protein. They do secrete a little bit of thing called offshore protein, but not significant protein. So for protein to occur in significant amounts in your urine, your glomerulus has to have a hole. Something must be going wrong in the glomerulus. So we know the glomerulus is inflamed. Right? So we have, from the presentation, we have worked out the pattern. But it is glomerulonephritis. Endocarditis is associated with glomerulonephritis. Okay? So how do we treat? So what do we do? So renal biopsy, I don't need a renal biopsy, I have the diagnosis. Okay? Methylprednisolone, not at this stage. It's a bit controversial in endocarditis. Some people do tend to give it, it's very severe, but it's not certainly not in this patient, it's just a creatinine of 3.2. Dialysis, no indication for dialysis at present. Stop the gentamicin? No. Gentamicin is actually treatment. Okay? So in the infection-associated glomerulonephritis, treatment is pre-infection. When the immune load goes up, the glomerulonephritis will settle. Actually 50% of patients will improve with that. This patient did actually settle. Okay? All of the above? No. None of the above? Yes. So that would be my the kid's presentation. Okay? Why you are laughing? Am I clear? Yeah. Very nice. So that is the first part of the discussion. So second part of the discussion. So now my MO calls me and tells so EGFR at 1.6 here for then 3.2 this side. So So I said EGFR, so EGFR is 50 2 days back and 20 now. So I said EGFR can't be 52 days back and 22 days now. So my emotions as a calculator is 52 days back and 20 now. I said can't be. So that argument is going on, right? So we'll talk until that settles. We'll talk about what is EGFR. EGFR is expected glomerular filtration rate. So people have done very clever things, and they found out that for a given sex and a given age, for a given creatinine, they can actually work out with a calculation the expected glomerular filtration rate. But that expected glomerular filtration rate to be valid has to fulfill some criteria. So one of the criteria is that the creatinine has to be stable. So when the creatinine is rapidly rising or rapidly declining, EGFR is not valid. So I say EGFR can't be 50 and 20. All those calculations come because the equation is not validated. That's it. Right? So what do we do? Now say your creatinine is 1.5 here, 3.2 here. Okay. If it was 3.5 3 days back, then it is stable. Then EGFR is valid. Okay. If it was 4.5 2 days back and 3.2 now, your EGFR is calculating the EGFR that should have been there to maintain it at 3.2. Now that amount of EGFR has been there, plus there has been additional EGFR to bring the creatinine down. So when the creatinine is coming down, your EGFR will actually underestimate the true GFR when it's coming down. Okay. තියාගන්න ඕන ගානට GFR එක තමයි කැල්කියුලේට් කරලා දෙන්නේ. නමුත් ඇත්තටම තියාගන්නවා වගේට අඩුත් කරලා. ඒකද ඇත්තටම GFR එක ඊට වඩා වැඩි. The opposite happens when the creatinine is high. Okay? So that is calculating the GFR that should have been there to maintain. Now it's not maintaining, it's actually rising. So the GFR is underestimated. So whenever creatinine is rising, especially rapidly, it's best to assume that EGFR is less than 20. Okay? Or less than 10. Okay? And it's rapidly rising. Right? So now gentamicin is the treatment, but I have to tell them how to do the gentamicin safely. Right? Now, the people who refer to me are not stupid. If they had a valid, now gentamicin could be contributing to the AKI. Okay? So if they had a valid reasonable option rather than gentamicin to treat that, they would not be asking me. They would change that straight away. Okay? So my job is to tell them how to do the gentamicin safely. So a little bit about the pharmacology of gentamicin. Aminonucleosides in general, aminonucleosides, when you give it, the half-life is like 2 hours. Okay? It's a rapid peak and then comes down quickly. But there's tissue absorption. So during the peak time, it will absorb into the tissue. And then at low levels, it will keep releasing also. So the kidney damage occurs during that peak. Because it absorbs into the kidney and then damages the kidney. Okay? But there is it's saturated. You can level at a certain level, the kidney will stop taking off. It can't take up anymore. So we don't mind how high it goes. After it goes above a level. But we don't want it to be high for long periods. Okay? We want it to be high for a short period. The bacteria would shot quickly and then leave the gentamicin level low for some more time. Right? So we like infrequent doses, once daily doses or even less frequent. Okay? So does that work out in practice? Yes. This trial. Cystic fibrosis, they did a trial actually, just people give compromising at less frequent doses and more frequent doses, and they found that the less frequent doses were equally effective for less nephrotoxicity. So it does work in practice. So we tell them to give gentamicin at less frequent intervals, but don't stop, go on, and we adjust the dose for that. Right? Secondly, the half-life of gentamicin is prolonged. I said it's 2 hours in normal kidney function. With impaired kidney function, it can be up to 30 hours. So we give a lower dose and all that, and then we keep them well hydrated, avoid the nephrotoxins, but we continue the gentamicin to benefit, and that's why we actually recover. Any questions on that? Yeah.
You said that the EGFR is no longer valid when the creatinine is rising.
Right.
But if you take drugs that are prescribed, the dose recommendations are usually for creatinine clearance. Is creatinine clearance more relevant in the rising creatinine setting?
If you can measure your creatinine clearance, that's fantastic. That's fully valid. But if you're going to EGFR, expected glomerular filtration rate, it's not valid in fluctuating creatinine. So if the creatinine is rapidly rising, it's safe to assume a very low EGFR, less than 20 or less than 10. Whereas if it's coming down, you can think your EGFR is a little bit higher than what it is calculated.
Yeah. nature. So gentamicin is done because our clinics some plans to go. So you have your gentamicin, they can check and adjust the dose as well.
Yeah. So ideally that should happen. When you are giving gentamicin to a patient with renal impairment, definitely they will take the dose. Or any other emergency. Here you don't have that freely, so you would. Right. Can I go to the next case? Any more questions on that? These are things that I have done and I have, assessed. So if I'm wrong or if you have any doubts or alternatives, you're welcome. Even the junior people, sometimes the junior people have the best comments. Yes.
One more thing.
Yes.
You said that we decided that this was a glomerular nephritis because of infective encephalitis because there is no red cell count.
Red cell count and protein.
Yeah. Is it absolute necessity to request a dysmorphic red cell?
No.
Really say it's a glomerular nephritis?
No. Dysmorphic red cells is one of the most useless investigations in my opinion. Okay. Even in the foreign center that I work, they did check for dysmorphic cells. I don't want to go into detail on that one, but in my experience, that's a useless investigation because there are various things that can cause dysmorphism. So if you're using that, you better read up the literature and then decide for yourself whether it's worthwhile. I personally don't think it's worthwhile. Whereas red cell cast, it's pretty good. Anything else? Can I go on to the next one then? Yeah. Right. Then I got another referral from the surgical ward. Now this time, a 40-ish something male came with 10 abdomen and then referred to me because creatinine was again 2 point something and potassium was 6.9. Okay, I went and saw the patient. I said, let's meet him. Okay. Now, potassium is 6.9. So in my clinic, pre-clinic, I will see a potassium of 6.9. Now, 9 times out of 10, I won't even admit that, let alone balance. Now, this patient with the 10 abdomen, potassium 6.9, I decided immediate balance. Why? Can anyone tell me? Sir? Someone say something? Huh? Yeah, that's one thing, of course.
The acute price of potassium.
Acute price, again correct. Acute price, the body will tolerate less than a chronic price. The most important thing is now in the clinic, when the potassium is high, I know what is happening. And it's something that I can do something about, so I don't like to some other drug and then I take out, put a milligram bicarbonate, hydrate, give some laxatives with that concentrated, then I can get it out. Here, the potassium, high potassium is most likely to lead to the acute abdomen. So I can't do anything more immediately. Okay? So the potassium, that potassium is going to keep going up, whereas my clinic potassium is going to start coming down when I do it. Okay? So that one I allow, this one I have to that. The 6.9 is going to be 1.5 next time like that. It's going to be 8.5. Right? So I decided to dialyze. Right? So then I went to the dialysis unit. I was sitting there waiting. Patient did not come. Right? So then I called the ward and asked, you know, put it out on the middle of the dialysis. If I was there, after I was going to over dialysis, I never would have seen it. What do you think happened? What do you think happened? Next day I was called to see in the ICU, patient potassium was 4.9. Okay? So surgeon was very correct, I was wrong. You know why? Potassium is now the patient has a thin abdomen. So most likely the potassium is coming from there. So there has to be nephrotic bowel. There has to be nephrotic bowel. Right? Now the intracellular potassium is 100 to 150 millimoles per liter. The extracellular potassium is 3.5 to 4.5. So the extracellular potassium load is massive. So when you have a necrotic bowel, you keep on putting out potassium. So if I put the patient for dialysis, at the most, I could have done a 2-hour dialysis and stuff, at most I could have removed 20-30 millimoles. During that period, the patient would have put out more potassium from the bowel. So I would have done the dialysis and ended up with the potassium was low. Surgeon took a risk, okay, but brave decision, but necessary. Brave. If he had not done that, the patient would have died. So patient survived because of his brave decision and dialysis supported him. And so if you were about hyperkalemia, so the take home message in this story, if there is something going on, treat what is going wrong, and again also look at why it is. Too often I see patients getting calcium gluconate. That's like no one has thought why is potassium is high. Okay, and then it just goes on and on like paracetamol and the problem doesn't get corrected. Okay. So when you are treating hyperkalemia, you get a patient with life-threatening hyperkalemia, the first thing to do is calcium gluconate. Any calcium salt, calcium chloride is actually the best, any calcium salt. What does calcium do? The calcium stabilizes your cardiac muscle for 30 days. Okay? Starts almost immediately. Actually, I did a series of photos. A patient came with sine wave, pre-arrest rhythm. We gave calcium gluconate and took serious photographs on monitor. It's very science. Right? So calcium gluconate, and quite frequently you have to repeat it 3 or up to 5 times at 10 minute intervals. So if you are giving calcium gluconate to a patient, what are you trying to do? Your potassium will not come down. You are just trying to stabilize your cardiac muscle for half an hour until you can do something to save that patient. So patients are taking calcium gluconate is someone whom you would be expecting to arrest within the next hour. So that patient should always be your money. I get very angry when I see this calcium gluconate be given, patients with potassium of 5 point something, and no one is even looking at the patient. If you are giving calcium gluconate, if you understand the rationale behind that, you should be expecting an arrest within half an hour. The other thing I have seen some people giving calcium gluconate TDS. No point, potassium is like this for all 24 hours. You're protecting the heart for half an hour in the morning, half an hour at lunchtime, half an hour at night. So that is how you calcium gluconate is a life-saving drug, but use it properly. Give it in life-threatening situations and repeat it on a cardiac monitor, right? Then insulin dextrose, things like sulfonyl nebulization, bit controversial. Insulin dextrose is not a risk-free treatment. Again, I have seen it was just putting calcium gluconate, insulin dextrose, the potassium is 5.2 or something, and then potassium has come down to 4 point something, it's still good. In the West, if you give insulin dextrose, you have to monitor the sugars for up to 6 hours in your life. So it can cause various problems. Delayed hypoglycemia, all these things have to be reported. So give it with potassium 6.5 or more, or you're expecting some problem. It's just pushing potassium into cells, it's not removing potassium. So use it, but use it rationally. What you need to be thinking of is prevent the cause for the rise in potassium and eliminate potassium from your body. You can eliminate potassium from your body by urine, by stool, and by diet. Now, again, some people I've seen furosemide being given. When I ask why furosemide is being given, it's a urine output, which is the wrong answer. Right? Your urine output when it comes down because the GFR is low. Right? Your furosemide blocks the reabsorption. Okay, and you see a lot of urine. So you are just fooling yourself. What you want is the GFR to go out. No point in blocking the reabsorption. You can give it in fluid over an hour, but potassium is different. Okay, potassium is secreted in the cortical collecting duct. So if you can get a lot of fluid there by any means, your potassium will go up. So increase your urine output by any means. Use your furosemide, whatever, give a lot of fluid if the patient can tolerate, and maintain a good urine output. Your urine will remove potassium. Dialysis, stool, like get removed, and then look at the cause. So the take-home message I want to give from the story, anything, okay, not even hyperkalemia, anything, treat the problem, but also think of why this, right? And then get cause. Any question from that one? No question? Clear? Okay, right. Next I go to a bit of a complicated case, okay? I want to discuss this case, one reason because people who are interested in medicine might find it interesting, and then people who are thinking of doing exams and all that might find a lot of points here. Right? So this time, this was again 60-something-year-old patient who was in ICU, and then they called me and said, patient is acidotic, pH is 7.2. So I went to see the patient. Now this patient I went to see myself. I see patient potassium of, pH of 7.2. The previous endocarditis patient, the one I told you earlier, that one I set my MO. Why? Anyone tell me why? Any guesses? So my MO can manage. Reason was all three of my MOs at that time were girls. My anesthetist at that time was a real kukura. Anyway, I went to see that patient. He was also so acidosis, right? So then, when you have an acidosis, so normal pH is 7.35 to 7.4. Please correct me if I'm wrong. Figures, I just remember the rough figures of the second. Patient is acidotic. So whenever the patient is acidotic, the next thing, reflexively you should look at on the arterial side gas, the PCO2 and the bicarbonate. Okay. So what happens? Acidosis can be respiratory acidosis. To make it very simple, if it is respiratory acidosis or metabolic acidosis. In metabolic acidosis, your bicarbonate will be low. In respiratory acidosis, your PCO2 will be high. Okay. But then there will be balance compensation. So if there's respiratory acidosis, your metabolic will try to alkaline, make it alkaline. If there's a metabolic alkalosis, your respiratory will try to make it alkaline. Okay. So if you have a metabolic acidosis, your pH is low, bicarbonate is low, your PCO2 will also become low. There are various calculations to measure that will saturate enough or whatever, but not deal with that. So if both your if your bicarbonate is low, your PCO2 will be low due to compensation. The other way around. If your respiratory acidosis due to high PCO2, your bicarbonate will rise to compensate metabolically. Okay. So this patient, the bicarbonate was 10. So normal range 22 to 29. This normal range is 31. Roughly we say the broad range as a 22 to 29. This 10. So metabolic acidosis. Okay. PCO2, PCO2 was 20. Okay, PCO2 is 20. So from 35 they come down to 20. So they compensate. Right? So patient has metabolic acidosis. All clear up to that point. So now we go to the complication part, right? So when there's metabolic acidosis, automatically we go into what is called, we check what is called anion gap. The anion gap. Okay? So I will talk a little bit about the anion gap. So I'll tell you a personal secret before I go into anion gap, right? So nephrology is the least interesting thing in my life. Right? Nothing wrong with nephrology. If I did respiratory, that would have been the least interesting thing in my life. Or if I did astrology, then that would have been the least interesting thing in my life. Basically, I don't like to work. So, but anyway, in this field of uninteresting nephrology, for me, this anion gap is something that I find a bit interesting. Okay? So listen and follow and see. You also may find it interesting. Okay? So anion gap is now whatever you take, not only your body, even if you take this chair, if there are ions there, the anions have to be equal to the cation. Anions are cation saman. Nothing can be electrically charged. Okay, same in your body. Okay, so if you calculate all the anions in your cations in your body and all the anions in your body, it should all be equal. Okay, but then we can't measure all the anions in your body or all the cations in your body. Right? So if you measure the cations in your body, you have the sodium, you have the potassium, you have the calcium, magnesium, and a lot of unmeasured things. Right? So generally for our purposes, we measure sodium and the potassium. So those are the main anions. On the cation side, you have the chloride, you have your bicarbonate, you have your anionic proteins, you have this, that, phosphate, all those things. So you have a whole lot. Of that we measure the chloride and the bicarbonate. Right? So now the unmeasured anions, the proteins and all that stuff will be slightly more than the unmeasured cation. Actually, they are equal, but because the unmeasured anions are more than the unmeasured cation, there will always be a gap. Your cations will be more than your anions. So that is called as anion gap. Right? Now, if you have now on this side your chloride and bicarbonate are there. If your bicarbonate decreases and your chloride increases, okay, then the measured anions will be same, the more. So there will not be any change in the gap. Okay, so that will be a normal anion gap. But on the other hand, if you add some other acid into your anion side, right, then the whole thing will go down. The unmeasured stuff will increase. So your chloride and bicarbonate total will be much less. So if you see the difference between the cations and the anions, the gap will be large. So that's called high anion gap metabolic acidosis. Is one clear on that? Then the concept. Okay. So now this phase. Okay. I'll make it the figures more rounded to make the calculation easier. So we say here a sodium of 135, a potassium of 5. So cations is 140. Here a chloride of say 90. Okay. okay, 90, and by the update I told you was 10. So that is 100. So 140, 100. The gap is 40. So massive anion. Right? So that is big anion. Right? So normal anion gap, so also some various people say various things. Some people say 4 to 8, some people say 4 to 12, some people say 8 to 12, some people say 8 to 16, various things, right? So we take 16 as being the highest. I have never seen a normal even at more than 16. So if you say 16, this is 40. So this anion gap is high. Okay? So it's a high anion gap metabolic acidity. Okay? Can anyone tell me how to remember the causes for high anion gap metabolic acidity? Mud prices, okay? Or smart. Okay? You would have got full marks before 2008. After 2008, you will get 50% marks, right? So now when the anion gap is high, we know there's something else that has been added. So we want a mnemonic to remember what what has been added. So now, after 2008, there was a Lancet article where they recommended the mnemonic of gold mark rather than Kussmaul and Getman Price because it was more representative of patterns that we get now. So gold mark, G is glycol, ethylene glycol, propylene glycol, whatever glycol. O for oxyproline. Oxyproline is pyruvate because acidosis is the same. That is something that you get that is high interest area now. That is something we get with chronic paracetamol dosing in malnourished females generally. Okay, so you get a high anion acidosis in that order. That's pretty common, not uncommon, and that's recognized now. L is L-lactate, D is D-lactate for gold, mark A for methanol, A for aspirin toxicity, R for renal failure, and K for ketosis. So gold mark is the currently more academic mnemonic that you use. Right? So this one has to be having one of those. Right? So each of those. So we measure ketones, negative. You could measure the others. Okay? Right. So so with that we went to the next step. The next step is what is called osmolar gap. Okay? Osmolar gap is there are various stuff in it. Is it too complicated? People are sitting for example, others can go to sleep if you are not finding it too complicated. People are sitting for example, you can get some points like this. So osmolar gap is you can actually calculate your serum osmolality. Just take a bit of serum, measure the osmolality. So that will give you the true osmolality. Also you can calculate your osmolality. Measure the amount of stuff that is there that can cause the osmolality thing and then add them up, right? So when you are calculating your osmolality, it's sodium and potassium into 2, because all of them will have a corresponding anion, right? So sodium plus potassium into 2 plus glucose in millimoles plus blood urea in millimoles. If you calculate alcohol in millimoles, right? So this patient, so if that is much less than the measured osmolality, if the calculated osmolality is much less than the measured osmolality, again there's huge gap. Okay, that means there is some other unmeasured anion. So patient unmeasured osmolar function. Patient has taken some. Okay, so we measured this chap's sodium was 135, I think. Potassium was 5, that is 140. That 52 is 280. And he said blood urea was 5 millimoles. This will be rounded, and sugar was 5 millimoles. So again 10. So that is 290. So the measured osmolality came at 320. So 30 difference. So less than 10 is normal. Less than 10 can be anything. Okay. 10 to 20 can be the organic things. Ketoacidosis, lactic acidosis. Those things will also cause a bit of a osmolar gap. But if it is more than 20, it has to be something in it. It has to be something in it. Okay. So high osmolar gap will only be caused by sugars. Sugars means mannitol and those things. Paraproteins, dyslipidemia, and the glycol. Toxic alcohol. Okay. So the only thing that can cause high anion gap metabolic acidosis and high osmolar gap is toxic alcohol. So we are looking at toxic alcohol. Things like methanol, ethylene glycol, things like that. So ethylene glycol is something that you get in things called antifreeze. To stop your radiators freezing, they put something called antifreeze. I have not seen that here. JMO says that it is also brake coil. I don't know. I'm not sure. Right? Anyway, I have actually not seen ethylene glycol poisoning in Sri Lanka. Methanol poisoning? Methanol is there in all your cotton foods and all that, lab alcohols and all. Right? So we are left with the diagnosis of methanol poisoning. Okay? So just from those figures, we worked out methanol poisoning. Then we looked at the story to see this chap has got some alcohol from some labs and drank. Right? So we dialyzed immediately, we did everything, but patient died. But two other people got saved. That means two other fellows who had been drinking with this guy. Okay, so as soon as we got that thing, they have some of them saved, and then they got some good medical advice from someone. They started treating themselves. Okay, so what is the treatment for methanol poisoning? The methanol itself is not a problem. Okay, methanol itself is not a problem. Methanol metabolized to formaldehyde. Formaldehyde is the problem. Okay, so if you can stop the methanol alcohol dehydrogenase process there, if you can stop it metabolizing, then nothing bad will happen. The methanol will get removed by itself, removed as itself without going into formaldehyde. Okay, so the best way to block that is what is called ethanol has alcohol dehydrogenase has 10 times more affinity for ethanol than methanol. So if you have ethanol in your body, it will go for the ethanol and not the methanol. Right? There's another thing called fomepizole. Fomepizole has the affinity for alcohol dehydrogenase of 8,000 more than ethanol. 8,000 fold. So if you give that fomepizole, eat up all your alcohol dehydrogenase, and that's pretty safe. But I've never seen that being used in Sri Lanka. Abroad, 90% of the time that is what is being used. But here what we have is alcohol. Not that good, but okay. So the problem is you have to maintain blood level of 100 to 150 of ethanol for it to be effective. So these guys, for 3 days, they kept on drinking, maintaining a good alcohol. They got some good medical advice from someone, and both of them survived. So that's the truth. Any questions on that one? No questions. All understood. Too complicated. You can tell me, okay, if the cases I can tell 1,000 cases I've seen. So if one is too complicated, just tell me, I'll switch to the next. Is that okay? No questions on that. Just tell me, are you following me or are you lost? Right. We go to another case. Right. Okay. I get a referral from the medical board. Right? So there's this 40-year-old guy, swollen, okay, like a balloon. Lips are swollen, face is swollen, everything is swollen. Diabetic history for 15 years or something. Had laser treatment for proliferative retinopathy. So this was the patient. So presented the patient. Renal function, creatine was normal, serum albumin was low, 2 point something, urine albumin 3 plus in the US part. So metastasis, high low protein, low serum protein, and heavy protein. So I said, diabetic nephropathy. So I said, no, my was said nephrotic syndrome. So who is correct? I said diabetic nephropathy, her was said nephrotic syndrome. Patient is diabetic. Serum albumin 2 point something, urine albumin 3 plus. That was it.
If the proteinuria is, rather acute concept, then that would say it's
we don't know. We only have that report, 3 plus. So both are correct. But nephrotic syndrome is a presentation. Diabetic nephropathy is a pathology. I was telling you earlier. So diabetes is the etiology. It will cause the pathology of diabetic nephropathy. It will cause the presentation of nephrotic syndrome. So the presentation is nephrotic syndrome. So one of the things to tell you there is that all nephrotic syndromes don't give prednisolone. I have actually seen that. Like even diabetic nephropathy causing nephrotic syndrome, people are getting prednisolone. Okay. If there's nephrotic syndrome, that's a presentation. You can treat the presentation by getting fluid removed and all that thing. But then you have to look at the etiology and treat. So just blindly treating it, okay. So now, how did I say diabetic nephropathy? The patient has proliferative retinopathy. So proliferative retinopathy has a 90 to 100% predictive value for diabetic nephropathy, but 90 to 100. So there could be few patients who are not caught there, right? So the BP actually was a bit insistent on doing a biopsy. Initially, I didn't want to do a biopsy, but then we did a biopsy and found a diabetic nephropathy as expected. But no problem. Whenever you see a diabetic patient with high creatine or proteinuria or whatever, the first thing you should do is to make sure that it is diabetes and nothing more. In our times we have seen diabetic patients presenting with vasculitis, with that other glomerulopathies, various others. Okay, so first make sure that it is diabetes and nothing more. Okay. So the features that will tell you that it is diabetes is long-standing diabetes. If the diabetes is short duration, be alert. Okay? If the proteinuria is rapidly progressing, if there has been almost no proteinuria 2 months back and now it is 3 plus, as you said, then think of something else. If the creatinine is rising rapidly, more than if the eGFR drop is more than 5 per year, be worried. Be thinking of something else. Okay? If there are red cells cast in the urine, think of something else. If there are connective tissue disorder features, raw vitiligo or joint arthropathy, inflammatory arthritis, think of something else. Right? If it is long-standing diabetes associated with retinopathy, poor glycemic control, which is more likely, then of course, more likely diabetic nephropathy. Right? So first thing to do, make sure it is diabetic nephropathy and nothing else. Once you make a diagnosis of diabetic nephropathy, that patient, how would you treat? Right? So now, until quite recently, right, we had only one treatment for diabetes, other than immediate treatment for diabetes. We had only one, that was AC inhibition. That is either angiotensin converting enzyme inhibitor or angiotensin receptor blocker. Now we have few more options. So for 20 years after that, we had nothing new. Now recently we have a few new for treating diabetic nephropathy. I tell you because it might be useful in all your practices. So I wonder if you have seen it. You all have seen it. Now, diabetic treatment, diabetic nephropathy treatment especially, they draw this Roman house. So the foundation like this, or the flow is good education plus lifestyle intervention. Then you have 4 pillars, right? And on top of that, the roof. Roof is good diabetic control, right? The 4 pillars: 1, glycemic control; 2, pressure control; 3, lipid control; 4, drugs with proven benefit. Drugs with proven. Right? So glycemic control, pressure control, and lipid control, I'm not going to talk about that. So the drugs with proven benefit, there are actually now 4. Okay, 4 first of all, AC inhibitors and angiotensin receptor blockers. Okay, so don't never use them in combination, but one AC inhibitor or angiotensin receptor blocker, and use it full dose. Losartan go up to 50 mg, enalapril at least 10 mg. Right? I won't go into all the details about those things. So AC inhibition is important. Lot of studies. They have proven benefit, right? And just because your potassium is slightly high, don't stop your AC inhibitors and angiotensin receptor blockers, right? If your potassium is high, what is the recommendation now? Put them on low potassium diet, and you can give gut phosphate binders, not your calcium sodium, but there are new things now. Even with that, if your potassium is high, then you will stop, right? So AC inhibition and angiotensin receptor blocker. Secondly, now even with all that, they have some nice name statistics for that. Even with AC inhibition, they showed that a lot of patients will actually progress to end-stage renal failure, 30%, 40%, even with good AC inhibition. So we need something more to protect our patients. So then came the SGLT2 inhibitor, empagliflozin, dapagliflozin, canagliflozin, all this, right? Even in non-diabetic patients, this has been shown to be renal protective. So especially in renal patients, almost first line you can use. Actually not that costly. Now CC brand of empagliflozin you can get for 50 rupees, right? So less than half the price of a cigarette, right? A lot of people smoke, right? So those things, those are the second class of drugs. Third class of drugs is actually what I call non-steroidal mineralocorticoid receptor antagonists, right? So that is the drug is felonidipine, right? So that is the third generation of spironolactone. So spironolactone and eplerenone, the second generation, those are steroidal mineralocorticoid receptor antagonists. And now we got the non-steroidal. The main advantage of the non-steroidal one is that it doesn't cause much hyperglycemia, right? If you use a spironolactone, 2/3 of your patients will have to stop that because of hyperglycemia. If you use spironolactone even with your gut phosphate binder, 1/3 will have to stop. But yes, with this one, right? Thirdly, your GLP-1 receptor antagonists, those are your liraglutide, semaglutide. No one uses that because they are injectables and very expensive, but they are also proven benefit, right? So that is what is new in diabetes. For less than 20, 20 don't start. more than 20 can start, but you don't have to stop even if it gets out of 20 months down. You can continue as long as you want. Do you want me to tell you a little bit about this employee? Hands up, people do. Yes, sir? Okay. So, employee what they do is, now all your glucose in your blood is filtered from the glomerular. But in your proximal tubule, all of this is reabsorbed. So, this blocks the reabsorption. So, all that glucose will go out of your body and it will reduce your sugar. So, that's actually initially given as a hypoglycemic drug to bring the sugar down. But then they found that there are multiple benefits that is not related to this hypoglycemic effect. Right? Cardiac benefits, they showed in this trial called Figaro and then Fidelio trial, but they showed, the trial. There were multiple trials to show that they are, sorry, I'm talking about, forget the trials, okay? So they showed that there are multiple cardiac and renal benefits, okay? The problem is that now the safety profile is very good. The benefits far outweigh the risks. But there are few things you have to think of when you're doing it. One, it breaks down the sugar. Okay? Hypoglycemia is a very low risk with that, but if the patients are already at the low end of hypoglycemia, it can cause hypoglycemia. Secondly, it has a hypotensive vision. It can bring down the blood pressure. So it might watch for your blood pressure coming down. Thirdly, it's a diuretic, osmotic diuretic. Sugar is taking water with it. So if the patient is already on a lot of diuretics or dehydrated, it might cause further dehydration. It can increase infections in your dental area, not bacterial infections, no increase in bacterial infections, but fungal infections. So they have to maintain good perineal hygiene. Last of all, there are theoretical risks of increased ketosis and increased amputation. But those are minimal risks and you don't really have to worry about them. When you use it, keep a watch on your sugar, keep a watch on your blood pressure, keep a good watch on the hydration state, especially when the acute amp. You can actually stop with the acute amp. Right? How did I get there? Someone asked me something about it. Are you okay? Yes. Any questions on that, sir?
What is constituting type 1 and what should we use it in type 1?
I don't know.
It's not recommended.
Yeah, it's not recommended. Yeah. You need to get more time to do it. Actually, I don't know.
What is the expected pricing differentiation after starting further and
so 30% price with AC or inverted price acceptable. If there is more than 10% price, you have to stop. If the price is up to 30%, you can just continue. But watch for progressive price. If there is progressive price, again you have to stop. Same with SGLT doing this. You can drop the EGFR by 20%. That is acceptable. With temporary crossing, you can drop. Or can be crossing also. Clear? Yeah, I can see cases and you are on. What? Hands up people who want me to tell us what you know. I am just a bit of a, not a really clinical case. We have this community program. Because I have this Bakugadu Arakshan Padram in Kegalle, so we want people to donate money, we can care for dialysis patients. To make that a bit popular, we do community programs. Others are useless. So we go and measure the creatinine and sugars and all that in some places or something. So we went to measure we went to a temple, company of Covid, to do a program like that. So the nurses were checking the sugars and urine and creatinine. We were taking blood for creatinine, they were taking blood pressures and all that. So my almost 3 of them went, but they were taking their selfies, so I had to do what I was doing. So my nurses called and said that the patient was complaining of increased frequency of urination for a few weeks, right? And then they checked our VP sponsored and got us some fancy dipstick. You could check everything, lymphocyte checks, nitric oxide, the protein, the whole world. So we checked with that one, sugar was positive, but everything else was negative. And the lady was complaining of urinary frequency. What is the diagnosis? Blood sugar was 89. Sorry. Sugar was 1 plus, urine frequency increase. Huh? Vitamin? No, she was not taking it, but she was not taking it. Yeah. I'm looking at Chandra to Sita. You are pregnant. So pregnancy can cause glycosis, right? So there are several ways in which unexpected stuff can get into your urine. Okay? One is if there's excessive blood. So if your blood sugar is very high, the GFR, the glomerular filtrate, will contain too much sugar that the proximal tubule can't reabsorb. So all that will go into the urine. Okay? Or your glomerular filtration can be increased. It got so much fluid, glomerular filtrate that the proximal tubule can't handle, and then it might get abnormal stuff in your urine. There could be a proximal tubule defect, like Fanconi syndrome or whatever. Proximal tubule is not reabsorbing and things can get into urine. The things can get secreted in the process, Needle syndrome, Bartter syndrome, various things can get secreted. Distal in your ureters and things, there can be something with too much or so it's something that could be putting out unnecessary stuff. So in pregnancy what happens, your GFR goes up. So your proximal tubule actually can't handle that amount of filtrate. So sugar gets out in your urine. That's not actually a totally benign condition, glycosuria in pregnancy. Now, it can actually predict some harmful effects. But anyway, this lady, when we asked her further, she had misbehaved that she was pregnant, and I told her to get a pregnancy test and go to biology if that was negative. If that was positive, if that was negative, to come back to me. She never came back to me, so she got that one positive. Okay. Any questions on that one? Right. Right, I'll tell you one final thing. This is little boring. Right? This is actually a bit of a advertisement. Okay. Something that I want to raise awareness about. Right. I have this patient who came to the. So I have in Kegalle, I set up a dialysis unit. Now I have 5 machines. Okay. So I was in the private sector. This patient came to me with a fistula and all that. Was on dialysis somewhere else. Patient was 82 years old. Okay. I came to me and said, I'm from Kegalle district. They told me to come and get dialysis here in private sector. So I said, sorry, I can't go you dialysis. I can't see you, refunded money. Asked him to go. So then I came out. Another man came. He said, I got dialysis from him. We have a learn. So private sector dialysis nahi hai. इसको चार डाल देंगे इसको मान दिन है इसको चार को इधर करने के हैं and then we started regarding so can I refuse to take on a patient in the private sector? Okay. It's actually a contractual agreement. If I see the patient, then contractually I'm taking on responsibility. But in the private sector, I can take the agreement. In the government sector, I'm employed by the government. I'm in a contractual agreement with the government. So if the government is taking the patient, I have to see that patient. Okay? In private sector, you can not see. So I'm okay. And again, I can't give dialysis in the government sector. The private sector, they also, I'm okay. But if that patient came to the government sector, then what would have been the problem? Okay? Now, they've shown in dialysis, like in surgery, the most important thing is when not to dialyze. Right? So they've shown in a lot of studies, when you're more than 75 years old, I'm talking about not acute dialysis, not if you offer treatment or something. The patient will recover. But if the patient is like in chronic stage renal disease, dialyzing a patient more than 75 years, there's no mortality advantage. The patient will not survive any longer, he will die. So that's unnecessary, especially if they are comorbid. So this patient of 82 years is not going to gain advantage. So that's one. Secondly, if you talk about medical ethics, the justice principle of medical ethics, there are a lot of details about what is called limited resources. So dialysis is a limited resource. So when you are dealing with a limited resource, you can't give everyone equal amounts of a dividend. Right? Everyone has to have an equal opportunity to have the limited resource, but everyone can't have equal amounts. Right? So, if we have one umbrella and it is raining outside, if you are going to go across the road, all of you can't say, I want an equal part of the umbrella and go under the umbrella because everyone will get it. Okay? But we can select everyone can be given an equal opportunity, and we can select the person who will get the most advantage from the umbrella. So if I say, English out, tomorrow eat it, okay, fair enough, use that. If someone says, Monica, Tamala, eat it, the tabella will not depend. It is advantage, so because of that one can't be there, right? So it has to be equal opportunity, not equal amount. So same with dialysis. Now ideally dialysis should be done twice a week, okay? But nowhere can we do twice a week. But in my unit I always do twice a week. I don't take any more. So twice a week, and after that I can't take any more. The problem with challenge is we get so much pressure from staff, from politicians, from planning, from that. And the other thing, the Sri Lankan health system does not limit treatment by district. So patient can't say because he's from Kegalle, he has to be treated at Kegalle. They have the access in there. Okay? So, so the problem is we under so much pressure. Actually, when I was in Corona, also death stress from anything. So I did take his child far for 80 years old. Okay? So we under a lot of pressure. So I like to raise awareness about this, right? What happens generally is patients now say it is my father 8 years old, right? So I am a layperson. So I think after somewhere, and then someone says dialysis, and the patient goes on dialysis. So no problem, taken to hospital, dialysis done there. But after a couple of dialysis, they say private dialysis and take it to private sector. But it's okay, they get the care of them. So they get money from that and then die. But maximum 3 months, they are the care of the rich. And then they have to pay. Right? Then one dialysis, 10,000 rupees. If they do 8 dialysis per month, 80,000 rupees. Right? Once you start dialysis, you can't stop. Okay? Once you start chronic dialysis, it's very difficult to stop. And their survival is very poor. So then what happens? They sell their house, they sell their study field, they sell their bike, they sell their whatever they have. Not only them, even their children drop out of school. Right? But one thing I'm proud of being a nephrologist, although nothing else, no one has had to sell his house or his bike or anything because of me. Okay? There's hundreds of cases. Actually, if you come to my private sector selling this thing, I have a notice to say don't come here to ask for dialysis. A lot of patients doing dialysis in the private sector come in and say, and all that. So I want to raise one example about the dialysis. Now, when we were even registered, the dialysis was only available in 10 years term. At that time, none of these patients were being dialyzed. So now there's a bit more, but again, it's a limited resource. So you are limited to a different case. And after 25 years, they are not going to have any benefit, just suffer. Right? So when you come across these patients in end-stage renal disease, especially people who are dialyzing somewhere, who are about to go on dialysis, counsel them properly. If you can't counsel them properly, refer them to someone who can counsel them properly and start properly. So dialysis, I just want to tell you the ethical principles about allocation of limited resource and the current situation of dialysis in the country. Okay? So we know not to die. Again, in the acute setting also, if a patient is very unwell, poor quality of life, the terminal event, acute kidney injury will always be part of the terminal. When they are going to die, they are going to have acute kidney injury also. At that time, dialysis is not involved. Okay? So know when not to dialyze, and think about what you are trying to achieve by dialysis. When you are trying to dialyze. Otherwise, you will be causing a lot of harm.
I have just one question.
Yeah, sure.
So, we quite often use cyclogalactan in this for long-term injury. What advice can you give us?
Yeah. So, one thing, it's actually a very important question. One thing, nitrogenate or sulfoxyl or whatever, these are not absolutely contraindicated, even in renal disease. Okay? So, you have made a very big product with patient, working your cardiac නැත්නම් කැක්කුමයි මොම් මුදේ වයින්නවා කියනවා නම් මේ කැක්කුමින්ද ජීවිත රැගෙන නැහැ කියනවා නෙවෙයි. Can't help. So, we get product if you have no other option. But on the other hand, if you have other options, if you have renal disease or are at risk of renal disease, try to use renal friendly things. The biggest problem that we see is inward. Right? When they come in inward setting, some especially HOs reflect their diclofenac cirrhosis, not even paracetamol. So we have this analgesic ladder. Start with paracetamol. Now paracetamol, the analgesic efficacy, you know better than me, is almost equal to diclofenac or sulfoxyl. It's only the anti-inflammatory effect that is more with the sulfoxyl than diclofenac. So start with your paracetamol. Then if you have to go for something, if there is risk of renal disease, then balance your basic doses. There's no absolute contraindication, but if they are at risk, then try to prescribe. Most importantly, don't jump your analgesic ladder and give diclofenac and ceftriaxone before paracetamol, especially in the acute.
But the issue, okay, it's a real diabetes.
Yes.
Earlier we used to see. Now do you practice it?
The type of technology that you're talking about, we don't use now. So those where we use this semi-rigid catheter. I'm sure most of us, most senior people will know, are coming to a catheter, you start putting into the tummy and do dialysis. Most of us have already done. So that is associated with a lot of complications. So that is no longer done. So now we do on the chronic setting, we do peritoneal dialysis. Actually, Kegalle is doing, I think now, about 200 cases. So there you put a flexible catheter. You put a light bar, on top of that you put a dilator and take out the mother of the dilator and do that to feed the tube. It's a flexible tube. That is very flexible, that is causing damage. That one is used. That is also used for acute dialysis in other countries. In Sri Lanka, that is not being used so far because the dialysis catheter things are very expensive and difficult to get. But in the acute chronic setting, that catheter can be used. The thing that we used to do in those days, nowhere in the world are they reaching anymore. Too many complications. It does work, but too many complications. I think Rajeeva in Kurunada is doing a few acute dialysis also with this. Yes.
So in normal clinical practice, we see that circulatory range marginally high, like 1.3, 1.5. Usually, 1.5 calcium not basic.
Not really. So first thing, don't make any decisions based on creatinine. So if your creatinine is 1.5 and you're 80 kilogram, you are a 20-year-old young man, that is almost normal. Like if you are a 70-year-old small female, that is advanced creatinine of 1.5. So always look for the EGFR, right? So even once later EGFR, that's what indicated for calcium carbonate and 1-alpha. Especially in advanced renal disease, they have calcium retention. So you tend not to give calcium carbonate. 1-alpha can cause what is called adenic bone disease in renal disease. So again, don't use indiscriminately. I also use sometimes because some people say what good way would be done. And then sometimes you get someone saying the nephrologist balak 1-alpha calcium carbonate or done. The patient gets sometimes demanding patients. I like placebo medication. But there's no scientific indication there. The scientific indication comes if you check your calcium, phosphate, alkaline phosphatase and PP. Right? So calcium carbonate, if you give it with meals, it will bring down your phosphate and raise calcium a little. If you give it away from meals, it will raise your calcium. So if you have low calcium, high phosphate, calcium carbonate is low. Your 1-alpha you give more than anything else to suppress your PTH. So if you have very high PTH, alkaline phosphatase can be a surrogate marker for PTH if you got measure. PTH is very difficult to measure. Then you can use your 1-alpha. But 1-alpha will increase the calcium and phosphate. Now calcium and phosphate high is actually detrimental. It will cause soft tissue calcification, various other problems. So you like to keep it at the lower margin of normal. So after checking all those things you can use, but don't risk it. Okay, unless you are reading like a person.
So at what point the erythropoietin
Erythropoietin should be used if the HB is less than 10 and there's no other cause. Yeah, so your target is some guidelines say 10 to 12, some say 10.5 to 12.5, one says 10 to 12, one says 10.5 to 12.5, one says 11 to 13. So you can choose any of those which you like and you at that. Don't over it. If your ratio of hemoglobin to more than 30, then mortality goes up. So iron deficiency can coexist in renal disease. So then make sure that the iron levels are also set when you are using it. Yeah.
PTH for the says to maintain about 2 to 3 upper limit normal because of
the guidelines are very vague. They don't give a limit. What they say is look at the trend. So 2 to 3 upper limit are normal, it's okay. But if that is rising, then treat aggressively. If that is coming down, go slower, so on and so forth. There are in Sri Lanka we have only this 1-alpha calcium carbonate. Abroad you will have lot of things, pericalcium, acid, these black non-calcium based phosphate binders. The options that we have are limited, and even the international guidelines are very vague. on this calcium phosphate. One thing is, don't give 1 alpha calcium carbonate. At least there's no indication to give 1 alpha calcium carbonate to all CKD.
If you are using ALP as a surrogate marker, I mean, what range should you target for?
First of all, make sure they don't have liver disease or any other cause of disease. If alkaline phosphatase is, maybe 1.5 exact amount, but say if it is 1.5 times more than upper limit of normal, then you can use 1 alpha without any fear, because that is that's not going to aid with bone disease. If there's already no diet with bone disease, alkaline phosphatase shows the dynamism. If there's no dynamism, we might push into aid with bone disease.
So regarding oral hypoglycemic agent, what are the this drug
This drug, metformin is still given as first line, but if there's renal disease, first line is SGLT2 inhibitor. Second line is GLP-1 receptor. That's you have to write that kind of thing which no one uses. But metformin nothing can be used looking at the EGFR of the sulfonylurea. Glyphosate is a bit of a problem. Glyphosate you can use without dose adjustment, but risk of hypoglycemia is increased with anything in renal disease. So watching for hypoglycemia, you can use glyphosate. Sitagliptin, you have to reduce dose at EGFR less than 30. Linagliptin, you can use down to 80 mg. Metformin, you can use full dose. Full dose is now 2 grams per day, not 3 grams per day. 2 grams per day you can use if EGFR is more than 40. 30 to 45, maximum is 1 gram per day. So 500 mg. Less than 30, you generally tend to stop, but at specialist level, some people go down to use 500 milligram per day down to 50. Don't try to use that at not 50. Actually, metformin does not cause lactic acidosis. The Cochrane review says that, but still it can actually make your blood a little bit more acidic. So generally not given. So am I taking two now? Anything else? You stop there.
I think the slides would have moved, I mean, feels really good. I mean, it's almost like a direct interaction, and in the case discussion we covered a huge amount of nephrology even in a very short period of time. So, and now it's
Thank you, sir. Now I would like to invite Dr. Miley Pires, the consultant physician, to hand over the certificate and a token of appreciation to our guest speaker. Sir. Thank you, sir. Before I move on to the vote of thanks, I would like to share a few three slides, of course, which I took from the Facebook without permission, actually. Sorry for that, sir. I just wanted to share this screenshot to see to make you aware that he is not only a specialist in nephrology. He is specialist in this field also. He's a good poet, and this is the recent success that he has got in the cultural, the Students' Festival of Literature, Magidesha Avadikaranamana, which is organized by the University of Peradeniya. He has got the first place in the poetry in the open section, and as our President has told earlier, he is a black belt in judo, and he must be happy and proud father to see that his children are also going in his same path. And thank you, sir. Thank you, sir, for being with us. Thank you for sharing your knowledge with us, and thank you for spending a valuable time to improve the knowledge and skills in our doctors in Matale hospital. And thank you, sir, again. And I take this opportunity to thank our president because he is the one who took the initiative, and he badly needed a lecture on nephrology, and he is the one who spoke to Dr. Rajeeva sir, and organized this lecture. Thank you, sir. Thank you for organizing this lecture. And last but not least, the participants, and we had a good participation today. Thank you all the consultants and the medical officers for being with us today. And we are having adult ALS program on October 12th, and we'll be having another poem session in සිංහලෙන් අපි කරනවා මොකද්ද සුහර්ෂිනීගේ presentation එකක් කරනවා. We'll be having on most probably on 25th of October at Director's Auditorium, and it will be open for all the other people, the nurses and minor staff. So hope that you will also be coming to that event. And we will have having the biggest event on November 3rd, the biggest program. We are having 33 children participating in that event, and hope that you all will be coming there. And thank you for coming today. You can collect the lunch from here. Thank you. Sir,